Hello, everyone. Welcome to another episode of Darshan Talks. We have Kenneth WhitE with us again, and Kenny is an attorney. He works with managed care organizations.
This is the Darshan Talks podcast, regulatory guy, irregular podcast with host Darshan Kulkarni. You can find the show on Twitter at Darshan Talks or the show's website at darshantalks.com.
I am thoroughly not doing justice to the many things Kenny's done. So, Kenny, would you like to introduce yourself first?
Sure. I'm Kenneth WhitE. I'm the National Managed Care Practice Leader for Willis Towers Watson. But before Darshan does it for me, I'll tell you I'm speaking on my own behalf and not on behalf of Willis Towers Watson. I have been in this role for 7 years almost now as the senior consultant with regard to risk and solutions for health plans, provider-owned health plans, risk-based reimbursement providers, and other entities like that. And prior to that, I was in private practice for almost 30 years as a healthcare lawyer, representing managed care entities, physicians and hospitals, and whatever they got themselves in trouble for.
So, Kenny, before we jump into the topic I actually have in mind, I know Kenny from the American Bar Association, where I am chair of the life sciences section right now. Again, not speaking on behalf of the ABA. But Kenny, are you do you have any kind of leadership role at the ABA right now, or what do you have?
Yes, I am chair of the managed care and insurance subsection.
All these chairs. If we get enough, we can set up a dining table.
Yeah, but we could have a whole dining room table, right?
We could.
They finally made me be chair. I this is my second year as chair, but I joined the health law section as a when we first started the health law section years and years ago, and had avoided leadership roles for decades, and then
avoiding leadership roles.
Yeah, well, I mean, you got other things to do, right? So about 8 years ago, maybe 9 years ago, I was a vice chair for the managed care and insurance interest group. And then I moved from every vice chair available. They will only let you do it for 2 years, and then you have to move. So I've done all of them, and they told me last year, 18 months ago now, that if I didn't become chair, that I was going to have to age off, so to speak, the leadership roles for the interest group. So I took the chair, and then I will be chair until our appointments run September to September, don't they?
I think July to July. But
right, so until next July.
Yeah. Very cool. Well, anyway, so the reason I wanted to emphasize that is because I want to point out how much Kenny knows. He has literally gone through every chair there is, every vice chair there is, before he's finally been relegated to becoming a leader. I'm so sorry, Kenny. But
it's a tough life.
It's a tough life. So the topic we have today is something I have personally been interested in for well over a decade, if not longer. And you briefly alluded to that. I can't remember if it was during the podcast or after the recording. But we were talking about how entrepreneurship is critical for the growth in the U.S. And one of the key components of that is making sure that you have health insurance. And as you're keeping track of health insurance, one of the things we discussed was that one of the struggles I as an entrepreneur feel, but I know several other entrepreneurs feel, is I need a job mostly for the health insurance. So how do I go about getting health insurance if I don't have a job? And it's sort of, am I stuck in the job until that point? So Kenny said there are several options, and we decided to make a podcast about it. So Ken, do you want to start off by telling us, first of all, what options do we have if you're an entrepreneur to get health insurance? Where do I go? Where do I start?
Well, let's drop back a little bit further than that. The entirety of the insurance business from thousands of years ago, when other people or entities took on risk for other things, jumping into the mid 1400s and 1500s, and when people were insuring voyages, on the high seas, et cetera. It's all been entrepreneurship. It's been, how do I take money that I have, capital that I have, aggregated capital and extend it to others, sort of as if you were loaning it to someone in order to get a return on that investment. So every entity out there that provides managed care services, we used to call it health insurance, but there are very, very few actual true health insurance indemnity companies left. Most everything is a managed care entity of one way, shape, form, or fashion, whether it's self-funded health plans or commercial health plans or association plans, or now you have the religious-based health accounts that you pay into that aren't really insurance or managed care. So that there's all of that is a way to use capital to provide a good or a service or a return on investment. So whether it's a PE company or venture capital company getting involved in the ground up for an administrative services company that aggregates physician groups to participate in value-based contracting, or whether it's Oscar, the health insurance company, the managed care entity, that those are all basically the same thing from an entrepreneurship concept. They see a need, they aggregate capital, they put it into the marketplace, and hopefully get a return back on it. From an individual standpoint who is looking to be able to manage their life in a way that they want to, it's the same thing. You can't, what was it, Maslow? Is it Maslow that had the hierarchy of needs?
Maslow's hierarchy of needs.
So, I'm sure health insurance is somewhere on that chart. I haven't looked at it lately, but I'm certain it's somewhere between food and clothing and, the achievement of nirvana. It's very, very difficult to live a life, particularly one in entrepreneurship, where you do not have the ability to fall back on a collective effort to provide you with the cost of covering your health care, whether it's just you individually, or particularly if it's you and a family, where you need to provide for a spouse or a partner and children in order to be able to concentrate on starting a restaurant or building a business of something else. No matter what your goals are, one of the things that you need to have in order to proceed forward, and if you have a idea of size and you get it off the ground, and then you start running into the regulatory requirements of either state like California or New York, or federal under the ACA, where you have to provide insurance or pay fines, or you have to be able to provide them with finances so that they can go into the ACA market and get their own insurance in order to have employees. Not only do you need to do that in order for you to have regulatory compliance, legislative compliance, but you're not going to get the employees to work for you, as you mentioned a few minutes ago, without having health insurance. A lot of people have a job for that very reason. I need the benefits. I need a 401k. I need a pension plan if I got one. I need a health savings account. I need something that provides a dissemination of costs associated with healthcare. So you can't pursue true entrepreneurship where you want to grow without having some backstop for your health, whether or not it's for your employees or for you personally or your family. So, that's where you start. That's where we were having the discussion before as to why you'd want to do this. Now, there are options for you. You can certainly, as an individual or as an employer, depending upon what size of a thing that you're talking about, go into the commercial small group market and purchase health plan coverage. You can, if you have lots of money, if you happen to be part of a PE or venture capital entity where there's a parent holding company, you can extend benefits down to multiple subsidiaries from the parent. If you have, if you're in an industry where administrative companies are frequent, and I'm going to use physicians as an example, where you have companies called medical service organizations or MSOs that are cafeteria style administrative service companies that you can pay a fee to, and they will provide all sorts of services to you, including employment and leaseback of employees so that you can get large group benefits for your small group at a large group price. So you aggregate your employees with others. We used to refer those as MIWAs, multi-employer welfare associations, I believe is what MIWA stood for. But the Department of Labor years ago started taking a very jaundiced eye look at them, put a lot of rules and regulations in with regard to what you had to be in order to be a legitimate MIWA, and they kind of faded from view. That was another way of aggregating that stuff. Obviously, as an entrepreneur, either with a small number of employees or just you and your family, you can go into the Affordable Care, the ACA exchange market and buy individual or small group coverage on the ACA. In some locations, although I wouldn't necessarily advise it, you can get association-related coverage. And then they have the newer versions of, most of them are religious or faith-based, where it's a combination of people who pay a fee, like a premium, but it's not a premium because they're not an insurance company, into a common fund, and you can submit claims. You can't see me doing the air quotes, but I am doing them, to this thing, and they will pay in accordance with their whatever the contract is that you have with them. And it's a way of spreading the risk, just like an insurance product, but it's not actually an insurance product, so it's not regulated by the state in most cases or the federal government, and you're going to get what you pay for there. Sometimes they work. Some people call them Ponzi schemes. Just depends. But those are all options that you would have as an entrepreneur without having to go without insurance.
So I'm sorry, I'm going to just, because this is fascinating to me, I'm going to list out what I think you just said. So number one, you can be a PE company, and therefore, if you have a bunch of different organizations below you, spread the health insurance down as well, so everyone in the organization gets it. Second one is the MIWAs, where you actually have the administrative companies, which are managed, essentially medical service organizations, and they let you aggregate your employees and go back down again. The problem is that MIWAs are basically going out of style because the Department of Labor was not a big fan. Is that correct? That is correct. Okay. Then there's the Affordable Care Act exchange, which is usually thought of as the federal exchange, but there's also the state exchanges, which is another location as an individual, as a family, or as a small group. You might be able to get it for yourselves. Is that still accurate? That is correct. Okay. Then there's the association-related coverage, which is not always advisable, and we'll talk about that in a few seconds. A few minutes, because I have some other questions. And then there's the religion or faith-based common fund, and they are either really great or a Ponzi scheme, depending on who you ask and which group you're talking about. Correct. Okay, so let's start with the state exchanges. First of all, I mean, everyone knows about going online and going to the federal exchange. How do you even know if I should be going to the federal exchange or to a state exchange? Is there like a list somewhere? Yes, there is a list at the Department of Health and Human Services or at any state level, Department of Health and Human Services, whatever individual states refer to them. You wouldn't have a federal exchange and a state exchange in the same state. In states where they have created their own state exchange, there is no federal exchange. The federal exchanges are for those states that did not create one. So, and I will use California and New York or
California, New York, Massachusetts, and a number of other states created their own state exchange. The state exchange is nothing more than a state regulated as far as eligibility to participate as a insurance carrier. And I'm going to call them insurance carriers, even though they're health plans. To participate on that exchange, you have to meet the requirements, the overriding requirements of the ACA, but your state may have additional requirements as well in terms of what things have to be covered, what bronze, silver, gold, platinum means in terms of benefits, and rates would all be covered or regulated at the state level. So in those states that created their own exchange, the state controls what entities can offer insurance coverage or health plan coverage on the state exchange, and what those insurance policies or health plans must provide as a matter of benefits, and what they can charge in terms of rates.
So that
the federal exchange is basically the same thing, but it's run by the Department of Health and Human Services, or CMS. It's not run at the state level, and they have their own. You have to apply to be part of it and offer the coverage, et cetera, comply with the ACA.
So here's my first question: why do states think that they can do it better?
Historically, healthcare was always delivered at the local level. It wasn't until halfway through the 20th century, 70 years ago, before you had any kind of mega, healthcare provider entity, with the exception of four or five large health plan entities out there now. Most all health plans are either regional or local, because they're regulated at the state level. That whole McCarran-Ferguson, Act stuff. You have Aetnas, but Aetna in many cases actually operates on a state-by-state basis under a different name, like Aetna of Texas or Aetna of Georgia, and Aetna is part of CVS now. Centene and WellCare do the same thing. Anthem is thought of as a huge company, which it is, but it's huge because it owns 14 separate Blue Cross Blue Shield plans that operate geographically. And then it has several non-branded entities like Amerigroup that operate in multiple states. But most, if you're not talking about Cigna or Anthem or Centene or United, Aetna, and Humana, if you're not talking about them, and quite frankly, they control 80% of the market share, everything else, was done at a local level. So state regulation of insurance has always been the way that it has gone. So states would prefer to regulate the insurance, whether it's called health plan, property insurance, auto insurance, whatever kind of insurance it is, that's offered to the citizens of their state. Because in most cases, if the insurance fails, then it falls back onto the state as a matter of, taxpayer liability. So they want to regulate, they want to ensure that the entities have the sufficient capital to pay the claims, et cetera, et cetera. So they'd rather do it at the state level. Now, obviously, with the Affordable Care Act, there was a great deal of politics involved, not just finance. So many states refused to set up a state exchange because they just didn't want to play. Mm-hmm. Now, I'm not jumping into that battle, at the moment, but I mean, that's why we ended up with, the federal exchanges in those states that did not have a state exchange, and then the state exchange. But that doesn't mean if you're Centene and you're on the federal exchange in the state of Idaho, I'm just picking that as an example, that the state wouldn't also have regulatory authority over Centene in the state of Idaho.
So please correct me if I'm wrong, but what I hear you saying is that if I am offering health insurance in the state of Idaho, and it's available on the Affordable Care Act, on the federal exchange, if you will, I would be my health insurance would be regulated by both the federal and the state governments. Is that what I hear you saying?
That is correct.
Okay.
Your exchange membership and your compliance with the Affordable Care Act would be more regulated by the federal government, and your existence and as a health plan in the state of Idaho would be regulated by the state of Idaho.
So, really simple question at a practical level for individuals or families. Are state exchanges generally better or worse? And again, this is an opinion-based question. And so what do you mean by the word better or worse as we define it?
I would assume that is very, very dependent upon the state. Obviously, larger states with a much larger pool of people who may or may not sign up for a state exchange. Now, remember something. When the Affordable Care Act was passed, they were talking about 40 million people not having insurance.
Mm-hmm.
Well, under the ACA exchanges, there's only about 10 million people that have insurance coverage through the exchanges out of 300 and however many million people we got in this country.
Interesting.
So the number of people who got coverage through the expanded Medicaid almost doubles what the coverage is under the Affordable Care Act. I mean, that's one of the things with the Supreme Court decision coming up. If they rule that the individual mandate goes down and that the exchanges are unconstitutional or whatever,
mm-hmm.
But sever that from the rest of the Affordable Care Act, which is a huge piece of legislation. The real concern there is not, so much the exchanges, it's the Medicaid piece, because that's much larger in terms of numbers of people covered. There are probably a number of people who have insurance on the exchanges now that could probably get health insurance not on the exchanges. There would be a few or some that would be hurt by it. But I mean, so saying something is better, that's, I don't know. Some states have a lot of choices. Some states don't. Some federal exchanges in certain states have a lot of options. Some don't. There are more options now in most states than there were 3 or 4 years ago. There were a lot of options at the very, very beginning. There was 3 years of extraordinarily bumpy rides in terms of finances, and a lot of entities dropped out of providing coverage on an exchange across, a given geographic area. So, but there are more participants now in terms of the exchange members than there were a couple of years ago. So there are options in most places. Most people have 2 or 3 options. Some places you have 5, 6, 7 to choose from. So, I mean, one part of better is the number of options you have to choose from. The other is what benefits are covered. In most states, I mean, the bottom level is the ACA requirements, and then certain states have additional requirements. So that's dependent on the state. And then, of course, it's a matter of cost.
Right.
I mean, that's one of the biggest things for an entrepreneur. I mean, if you're your standard entrepreneur, you've got
mm-hmm.
Your finances, your small business association loan, and whatever few employees you may have as you're trying to get something off the ground. Whether or not you're a small physician office, whether you're a 4-lawyer law firm, whatever, you have to provide these things in order to attract and keep employees, not only just pay for yourself and your family. So cost is huge. I mean, I know a lot of physicians who have gone the MSO route in order to get benefits at a lower cost, because you're also having to pay work comp, payroll taxes, everything else along with it. And that's a very difficult thing to to do if your health insurance costs are going up and up and up. I know several chiropractors who have jumped from the exchange market to those combined pay into the bucket, hopefully the bucket pays you back agreements, simply because it was affordable when buying insurance for themselves and their few employees just wasn't affordable. They couldn't cover it, and they couldn't pay their employees enough for the employee to go out. Now, I suppose that you could go out and only hire people who have other access to insurance. You know, lots of people out there, you know, if their spouse works for the state government, you know, or the federal government, they'll use that that insurance to cover that, so you don't have to pay for them. But, you know, you can't rely on that.
So before we continue, I just want to make sure I understand. You mentioned,
or maybe the answer is just go marry somebody who's got really good benefits.
That's a really sad state of affairs. If
Isn't it?
Insurance.
We used to marry people just so that we could immigrate. Now it's to get benefits.
I believe me, I know. But I'm not sure this is that much better. Okay, here's a question. You mentioned the chiropractor example. You talked about they paying into a bucket, and hopefully the bucket pays you back. And you sort of referenced that to be sort of like the medical service organizations. My question for you is two questions. Number one, were you saying that the chiropractors belong to MSO, or they have organizations like MSOs? And if there are organizations like MSOs, do lawyers have similar ones, and I don't know, engineers have other ones, or how does that work?
Well, all right. So let's look at two different kinds of association products.
Okay, so this would be an association product.
Sort of.
Okay.
There are lawyers, physicians, any trade organization, unions, particularly unions, offer benefits to members of that trade association that are usually contracted with through an insurance partner. So if you are a member of the American Pharmacist Society, I've forgotten the name of it, sorry. You know, I'm certain that you get emails or things in the mail offering you insurance through that entity. I get them from the Florida Bar Association. I get them from the Alabama Bar Association. I get them from the American Bar Association. I get them from AHLA, you know, where they send me because that entity has an agreement with an insurance carrier that is offering a discounted price on a group policy that you can access because you are a member of the group. What happened in the past, and the reason why the Department of Labor took a dim view of MEWAs and association health plans, is that entrepreneurs, some of them fraud, created groups like left-handed, redheaded people. Now, you were supposed to have an association where the purpose of the association was something other than offering insurance. And in many cases, it was completely just for the insurance part. And the rest of the association was a fraud. And a lot of times you thought that you were getting really good coverage when what you were getting was really horrible coverage, and they didn't pay claims, and it was a complete mess. What I was talking about with the chiropractor example wasn't an association health plan. It was one of these, a lot of them are faith-based. I don't think they all are, where you pay, you know, a stipend, because it's not, I can't call it a premium because it's not, into a bucket.
Right.
You know, if there's 10 of you, you all pay in. If there's 1 million of you, you all pay into the bucket, and you all pay in what you have to pay monthly. And then you submit claims and they pay out according, it works sort of like insurance, but it's not regulated like insurance. So you have to be cognizant of the fact that if they have lots and lots and lots of claims and didn't have a lot of money, or someone ran off with all the money, that's not unheard of, then there won't be any money to pay your claim. And you may have paid in for months or years into this bucket and then suddenly have $1 million claim for which there is no money to pay you back. And because it's not regulated as insurance, the state isn't going to step in, liquidate the insurance, company, and then pick up the costs of the coverage problems for the citizens of the state. So faith is a good idea, because you have some faith that these people are not fraudsters and that it's going to be run with a degree of actuarial soundness, so that if you ever have a claim, that the money will be there to pay. But I mean, not that I'm saying that all of them are like this, but not everybody lost money in Bernie Madoff's, Ponzi scheme. More people lost money than made money, but there were a few of them that made a lot of money off of that. Right. Because all of their stuff was getting paid for you just had to keep getting more and more and more and more people to support the weight of the pyramid. And, eventually those things crash. Same problem with Social Security, although you get people yell at you for calling Social Security a Ponzi scheme, but that's what it is. But, in that way, you can provide for yourself and your family some benefits related to healthcare costs, as long as that entity that you have joined is financially secure and not being run, as a fraud. And you just have to have faith that it's not, I suppose.
So we kind of covered, say, exchanges. We briefly spoke about association exchanges, but we'll talk about that. Association-related coverage. I'll go back to it. But since we're in the middle of talking about religious or faith-based funds, if you will, here's a really simple, a couple of questions that pop out of it for me. Number one, how do you ensure, do these funds negotiate rates, or if a hospital says this thing's worth $2,000, I'm paying $2,000?
Okay, so that depends on the sophistication of the entity, no matter what it is, whether it's the medical services organization providing group benefits to a combination of small groups that have joined, whether it's a bunch of unions that are together, whether it's an actual MIWA, whether or not it's one of these groups, or even if it's a self-funded health plan. The sophistication level of the entity depends upon what you do, and also the size. So you can, let's jump back a little bit. So you're an employer, you've got 100 employees, and you've decided that what you want to do is you want it to be self-insured, or you're making a decision as to be self-insured or fully insured. If you're in Florida, where I am, you can go to Blue Cross Blue Shield of Florida and sign up for group health insurance and cover everybody and pay the premium. Or you could create a self-funded health plan, meet the requirements of that, and then hire, for an administrative fee, Blue Cross Blue Shield of Florida to run your self-funded health plan. So now Blue Cross Blue Shield of Florida provides all of the administrative services that the health plan needs, but doesn't pay the claims. They're using the employer's money to pay the claims, as opposed to using their own money. It's just a matter of who's taking the risk. Is the employer taking the risk, or is the insurance company taking the risk? So what you want to do with those groups is, the more sophisticated you become, the larger you have, the more resources you have, because you have to pay for this. There's a fee involved. You would want to engage a third-party administrator, a claims administrator, a network building entity, in order to shift the administrative headaches of running that plan to another party, and then you would get their benefits. So if you had access for the fee that you were paying Blue Cross Blue Shield of Florida to run your self-funded health plan, you would have access to the Blue Cross Blue Shield of Florida network and their contracted rates. So yes, in that situation you would. In the association plans, that's hit or miss. I mean, if you're looking at the AARP association plan or the AAA association plan, those things have been around for a long time. They are very sophisticated. They have lots of members, and they have other entities, that are participating in running those. If it's the left-handed, red-headed people, probably not. So with regard to the faith-based, and I'm just using that because they're not all faith-based, the buckets that you just pay into, I'm not really sure whether or not those work, or whether I think most of them have an agreement with doctors or facilities who have contracted with the entity for a specific rate, but it's not going to be the deep discounted rates that you might get from a major health plan, because they just don't have the volume. I mean, if I'm Blue Cross Blue Shield of Florida and I've got millions of members in the state of Florida, I can go out to a hospital system and negotiate a rate lower than a lot of people could, because I've got the lives. And if you're not on my network, those people are not coming to your facility to get health care. So I don't think that the bucket type things have that. They don't have that negotiating power. But I think that most of them do have some loose arrangements with other entities. And they're also what I used to call, and I know it's a terrible thing to call them, the second tier networks. Three Rivers, Multiplan, all of those, where it's a secondary network that a lot of insurance companies use as well to expand coverage into geographic areas where they don't have a network built. But I mean, you could access those. You wouldn't get the same discounts that you would in terms of adjustments. It's that little line on your EOB when you get it in the mail or online that has insurance adjustment. They sent you a bill for $1 million, and then the insurance adjustment was $900,000. That's the contracted rate part. And then you pay your plan pays its part, and you pay your part, which is called co-insurance. But I mean, that's
I'm sorry, did you say poo insurance?
Co-insurance, CO.
Poof. Thank you.
So that 80-20 thing, or 70-30,
yeah,
where they pay 70%, you pay 30%, your 30% is called co-insurance.
Got it. So what I'm hearing, and correct me if I'm wrong, Kenny, number one, I think the association-related coverage is actually very similar to the faith-based or the bucket coverage. They're basically just buckets of money, or pools of money, if you will. And whether it's an association of redheaded stepchildren, or redheaded left-handers, or it's Catholics, or it's Buddhists, or whatever it is, they're all sort of managing a pool of money. The only difference being that the association-related coverage may actually be coverage, while the faith-based one may not actually qualify as insurance. Is that the distinction?
I think that the short answer is yes. The associations in some states are in fact regulated. They are loosely regulated by the Department of Labor. The buckets aren't regulated at all in most states, because it's just a matter of contract. There's no insurance aspect to it at all. So you wouldn't have hardly any regulation of those at all. There's been pushes, I think, in multiple locations to try to regulate them, but I'm not sure how you would.
Right.
I mean, it's not illegal.
So here are a couple other questions that pop out for me. One is obviously I'm going to recap and then go from there. So we talked about companies providing insurance through themselves We talked about MSOs. We talked about state and federal exchanges. Then we talked about association-related coverage, and we spoke about faith-based or religious funds, if you will. Obviously, there are two other, one other I can think of, which would be COBRA, which is really a continuation of your company providing the insurance. But I'm in a situation where my COBRA is expiring, and I'm looking at, okay, what do I do next? And they referred me to, I think it's called Health Sherpa, but then you mentioned Oscar, and I know like Amazon's doing some stuff. How do these things fit in?
Oscar is an insurance company. It's a health plan. So, I mean, it was founded by Ivanka's husband's brother.
Okay.
And some other people that formed Oscar in the Northeast. I think it's headquartered in New York. And they have expanded to multiple states. That's a full-fledged health plan that is growing. So that doesn't sort of, I mean, that falls into the, are there new entities joining that rank? And there are very, very few of them.
Why enter that market? It seems to already be dominated with the.
Well, that's the problem. That's why nobody wants to put money into it. I mean, I guess, you know, if you have a new mousetrap and Oscar, you know, considered themselves to be a new mousetrap, plus they had lots of financing, lots of money behind them.
Right.
And they have done fairly well. So, but there are very, very few of those. You have more entities joining the government program stuff, the Medicare Advantage marketplace, Medicaid managed care marketplaces, where you can trade on your name. I mean, if you're, and I'm just picking this out of the air, you know, if you're Emory and you're in Atlanta, right, and you've got a great name and reputation as being a health care provider, you could start a managed Medicare Advantage plan and be fairly confident that you could grow the numbers of people joining your health plan by trading on your name in a given area. I know that UAB, the UAB Medical Complex in Birmingham, has a health plan. I can't think it's called Vitas, or not Veritas, something like that. But that's the same thing. You know, they trade on their reputation as a provider in order to get membership on the health plan side, all the way up to entities, obviously like Kaiser and Geisinger and Partners, that all started as a combination provider health plan, to entities like Spectrum, which is a large hospital system in Northwest Michigan that has a health plan that's called Priority. And revenue-wise, Priority is actually bringing in more money than the health plan on the health provider side does. Or if you jump to Texas, where the Baylor Scott and White system is, they have the Scott and White health plan, but that's the traditional, you know, tail and dog situation. The health plan is much smaller in terms of everything than the actual health system. Priority and Spectrum is actually sort of reversed, where Priority is bigger than you know, Spectrum in terms of revenue. But you have to have money to make money, so they say.
Right.
So a lot of the entrepreneurial dollars, the PE money, the venture capital is going into administrative services companies that provide administrative services to providers. Providers historically have not been very good business people. You know, left brain, right brain kind of a thing, I think. So they will often, you know, pay someone else to handle that type of thing for them, and they get benefits of scale. So if I'm putting my money into the health insurance or health plan world, I may, rather than starting a PBM, I'll put it in pharma words, rather than starting a pharmacy benefit management entity, what I'll do is I'll create a company that assists other PBMs on identifying specific targets for reduction in utilization.
Yeah.
So I don't have to pay claims. I don't have to bring in members. I don't have to worry about, rebates. I don't have to do any of that stuff. My job is to help that other company save money.
Oh.
And there are lots of those companies that do utilization review management, companies that do pre and prior auth and post auth reviews of cases, tons of back to work entities that assist workers' comp plans and plans to get people back on the job faster so that you reduce the amount of workers' comp expenses that a company has. Lyft, was looking at this earlier, where Lyft today has announced that they're now interoperable with Epic, which is a big thing. So, if you're using non-urgent ride sharing to get your membership to the doctor or to the pharmacy so that they actually get the care that they're supposed to get, because I told people all the time when I practice law, it is cheaper to keep people healthy or to treat them after they first get sick than it is to treat them after they got really sick. So you still have to pay the bill. Right. So treating someone and paying for their stage 1 cancer is much, much less expensive than treating them and paying for their stage 4 cancer. Right. So that's just an example. But I mean, if you got into the ride share part of things, there are entities out there for value-based contracting that not only provide services for the administration of the office, but they do the contracting. They do all the billing and coding. They provide best practices and streamlining on how the care is provided to ensure or help ensure that you are reducing your utilization while increasing quality so that you get the bonus payments at the end of the year. And they are willing, because they feel that they're doing this really well, they're willing to, I'll split with you. If you make $100 on the bonus at the end of the year, I'll split it with you 50-50 so that you make 50 and I'll make 50.
Right.
But if you lose $100, it's all on me.
Right.
So there's a lot of those companies springing up, and all of those companies are geared towards healthcare savings, reduction in cost, quality reduction in revenue and utilization. You can't just say, don't everybody go to the doctor for that very reason. You don't go to the doctor, you don't get diagnosed, you don't get diagnosed, your blood pressure swings way out of control, you have a stroke, and it costs a whole lot more money to take care of you after you've had a stroke than you did if we could just manage blood pressure.
Right.
So there's a lot of those companies out there. So when you think about being entrepreneurial on that side, there's a lot of these companies that are not, I'm going to be an insurance company. That's a bad move, unless you're an Oscar.
Right.
But again, if you're on the entrepreneur side, if you're I need to get healthcare coverage so that my family has healthcare coverage, or my few employees, hopefully more employees later, will have healthcare coverage, there are options. Some of them, I can't tell you that any of them are cheap. Right. Most of them are not, which is why I think some of these people are drawn to the, pay into a bucket concept.
Right.
Because, they're looking at it from the same thing that a corporation looks at the cost of insurance. It's an asset to the entity, but it has to have a return. If I pay out $300,000 over my lifetime in disability insurance, but I'm never disabled, I, at the end of my life, collected nothing and burned $300,000 in my backyard.
Right.
You buy disability insurance, you hope never to be disabled. So it's sort of a weird thing. But if you're a corporation and you're buying errors and omissions coverage, you know that you're going to have errors and omissions claims. What you want is to pay less in premium over the years than you get back in the insurance coverage. Same thing with health insurance. There are lots of people out there who are healthy most of their lives through good living or genetics, and they or someone has paid on their behalf hundreds of thousands of dollars over their lifetime in insurance, and they've collected almost none of it back. But almost all of that has gone to pay for someone else, because someone out there is draining the system.
Right.
So if your family is healthy and you're basically just worried about the catastrophic situation, a cancer diagnosis, a stroke, a long-term medical condition where the costs are going to be very, very high, you're paying into this thing to help defray the cost of others in hopes that if it ever happens to you, that bucket will be there to pull you out.
Right. Are there, so two questions from that, and I know we're running tight on time right now, but one is it possible to just get catastrophic coverage? Is that a thing?
Well, most people would consider the lower tier ACA coverage to be catastrophic. One, most of them have high deductibles. So you're looking at a $3,000, $4,000, $5,000, $6,000 deductible.
Right.
And let's face it, if you had to have 90% subsidization by the federal government to afford your insurance coverage, you're not going to be able to afford a $6,000 deductible.
Right.
So most people consider that to be catastrophic coverage. Does it provide other things? Yeah, there's all plans like that have to cover the 10 basic I forgot what they call them, but I mean, contraception and preventative care and immunizations and stuff like that you get. So it's not completely without, benefit, but I mean, it's possible that even if you're only paying 10 or 20% of the cost, that you'll pay 10 or 20% of the cost and never get a dime back.
Right.
Which I always thought was one of the dumbest things in the world. Why are we paying subsidies? It's just subsidizing the insurance companies. That's all it is. But so you can buy catastrophic coverage. The question is that what you really want to do? I mean, I suppose that just depends on your financial circumstances.
My last question is something you sort of hinted at and I'd heard of, but I didn't fully understand which was sort of grouping it would fall under. You talked about like the Kaiser plan, and you talked about all these other hospital entities that have plans. Am I able, sitting in Pennsylvania, sitting in Philadelphia, to go, you know what, Kaiser, I've heard great things about your plan. I'd like to have it. And the side effect that comes out of it is, can I get coverage outside Texas or California, wherever it is?
You can only, those plans, whether it's a priority for Spectrum or whether it's Geisinger or whether it's Kaiser or whether it's any of the provider-based plans, you are only going to be able to access that plan where they have a network. Most of those entities, the primary network for hospitals and physicians is themselves.
Got it.
So my guess is 75% of the care that Priority pays for is from Spectrum or Spectrum physicians. But they wouldn't have a network in Detroit or in Chicago. So you can't buy the Priority plan. I mean, that's one of the primary differences between the indemnity plans for health coverage and health plans. So indemnity plans just paid you back. You paid in, there was a schedule of benefits, claims got submitted. It didn't matter who provided it or where it was. They paid whatever the plan was, whatever the insurance contract required them to pay. On a health plan, most of those are network tied. So even though you're not tied like the old HMOs, although there are still HMOs around and they are coming back. They just call them narrow networks. So where you're tied to a given list of physicians, specialists, DME providers, hospitals, et cetera, even on the expanded versions, the point of service or the PPOs, where you've got a larger network, you're still tied into that network, except for like urgent or emergent care. I mean, I'll use Blue Cross Blue Shield of Florida as an example. I mean, they've got the largest network in Florida. You could walk in basically anywhere in the state of Florida, and whoever it was that you're being treated for is probably contracted with Blue Cross Blue Shield of Florida. If you happen to be in Atlanta and you need health care coverage because of the Blue Card, you could go there and get coverage basically anywhere.
Right.
Because the Blues have that reciprocal arrangement between the Blues that allows you to use your card basically anywhere there's a Blue Cross Blue Shield physician or provider. But I mean, if you're an AvMed member in Florida, you have to use the AvMed network unless it's an urgent or emergent situation. And the same thing would be true if you were out of the network area. You can't just go get elective care in California and then send the bill to AvMed and expect AvMed to pay it. If you end up in an emergency room in California, that's a different story, but not if you just, went to California and decided to have, your tonsils out, whatever.
Right. Kenny, I know where you've been extremely kind with your time, but this was incredible. Thank you so much.
You're welcome.
I'm looking forward to having you on again.
All right, I will talk to you soon. And just for you, go Eagles. I now have to go wash my mouth out with soap.
Thank you.
I'll talk to you later.
This is the Darshan Talks podcast, regulatory guy, irregular podcast with host Darshan Kulkarni. You can find the show on Twitter at Darshan Talks or the show's website at darshantalks.com.